70s that they really started trying to come up with ICD treatment. And this was really pushed by the electrical companies, because they were tired of having to pay funeral benefits for their linemen when they got shot. And you get a bunch of electricity run through you, you end up in VF. So they wanted to know how to cure that quickly. So that's where a lot of the defibrillators came from, and then we started pushing that even further to try and do it with an implantable defibrillator. They've got some interesting things on the wall at Providence, but if you ever can get up into Dr. Machado's office area, one of the older physicians donated all of his demo stuff from way back when. They actually have a ICD from like this time period. It's the size of a small lunchbox that used to be implanted in somebody's abdomen, and then they would run the wires with that. So it's one of those things, if you ever can see any of that stuff, that's really cool. In the 80s, that's when we started to get smarter. We started moving to computerized systems so that we could actually evaluate the signals more in a real-time scenario instead of having to wait 2 or 3 days. And we also developed more surgical techniques for fixing more arrhythmias. This is when we first started trying to do some kind of current-based ablation. It was strictly for the AV node. One of my favorite questions is always to try and talk about how many different ablation sources are out there, and there's always one that everybody misses. Have you done that to them yet? Okay. So, and this is when we were doing early ICDs, and remember I said it was via thoracotomy. It wasn't the nice, cute little things. We would have to crack the chest, implant the defibrillator in the abdomen, and then run wires to the outside of the heart in order for that to occur. It's a lot more elegant now. In the 90s, this was when all of our mapping systems started to pop up. All right, I think it was in 2000, 2001, I saw one of the first mapping systems. It was ESI at that time, and their geometry, we used to make fun because when you would build the geometry, you know, they build the geometry and you get this nice picture of the heart and it really looks like what it's supposed to be anatomically. We would just say we were building a kidney bean, because there was no detail or anything like that. It was just this kind of weird globe with had a little bit of a thing sticking out on the side. It looked like a kidney bean. But this is when EP really started coming into its own, and that's because we're using catheters and radiofrequency ablation, which has become, of course, our #1 ablation energy source. All right? And we were working on all these different guys to try and see about fixing them. It was also the time when we started really seeing major advances in the device group. There's really 2 branches of EP when you break them down. The electrophysiologist manages both, but we have our curative, therapeutic, in the lab, arrhythmia-based, and then we have our device-based as well. So we try and fix fast arrhythmias that we can in the lab, and then we try and fix slow and fast rhythms that aren't curable in the EP lab or through medications with our devices. And the devices really started to get really, really important. We got pectoral ICDs. We actually got dual chamber pacing in an ICD. I doubt you guys will ever see it. I think the last patient I saw was in like 2004. She was 102 years old. She had an ICD and a pacemaker because ICDs didn't pace. All they did was shock. And one of the big things with those patients is we had to run studies to see how they would interfere with each other. Because if they had a real fine fib, the pacemaker would not pick that up and keeps throwing a spike, and that would throw off the ICD, and then it would never shock to save the patient. So we had to do a lot of weird studies with patients that had 2 different types of devices to make sure that they would interact together correctly to prevent therapy from being delivered. 2000, this was the advent of atrial fibrillation. I'm not even going to get started on the wonderful controversy going around about all that. This is where we started also seeing this was kind of like our AFib era, because not only were we doing catheter-based solutions for AFib, we were also doing device-based solutions. We actually had devices that had special, some of the leads would have special coils just to shock the atrium to bring you out of AFib. And this is when we started trying to do biventricular pacing for CHF patients. And this is one of my favorite ones. I've never liked devices. I'm a lab rat, want to stay in the lab. But we were involved in a lot of the early IV device studies and we were literally putting in devices that were dual chamber devices, and on the ventricular lead, we were like using a splitter and running 2 leads. Because there was no place to plug in for the LV at all. So we were doing all sorts of crazy things back then. And this is probably one of the most interesting things that we heard. We were discussing this, crazy enough, on our way to Nicaragua for one of our medical aid missions, I think in 2004. It was right before SCUD came out, which was a major, do you talk about that?
Yeah, we will, but they haven't gotten there yet.
It was a major trial that revolutionized a lot of things about how we did practice. And one of the things we found is, because we've been putting ICDs in for a while, we got some great numbers from the CDC. We found out that ICDs don't prolong life. These patients still end up dying in the same amount of time as they would if we hadn't given them an ICD for the most part. But what we did find is the patients that had biventricular devices had a higher quality of life, is registered by the fact that instead of being in the hospital 7 or 8 times a year, they only went into the hospital maybe 2 or 3 times a year. So we were increasing their quality of life. Now, CHF is an ugly, ugly disease, and one of the best ways I've ever heard it described is if you have a top, a little spinny top like you get for Christmas. Remember when we were 3? Do you remember? Okay.
But I was about 7.
Okay, all right. Okay, very good. So if you take that top and put just a little weight on one side and spin it, it starts spinning the way it's supposed to, then it keeps getting farther and farther out of the kilt, and finally it falls over. That's what CHF is. Once you have that injury to the heart, it starts losing its ability to pump, and it keeps getting worse and worse. And the only thing we've ever been able to do with medications and treatment in the cath lab is to slow down that process. But ICDs that do biventricular pacing were the first devices that were actually able to reverse this. We had one patient, he was 32, 33 years old. We wrote him up as a case study. His CHF was viral. He caught something while he was in another country, and basically he had an ejection fraction of like 12, 13%. I mean, horrible. 33 years old, he had a brand new son, and he couldn't get up off the couch and walk across the room to pick up his son without having to stop for a break. We gave him a device. His EF immediately from this device went from 12% to 20%. We saw him in the office 6 months later with the device on. His EF was 45%. With it off, it was 40%. It actually reversed his disease. I was watching him, and I don't get emotional over people. I was a Detroit paramedic. People suck. All right, but it almost brought a tear. I get emotional at 3 o'clock in the morning when there's like a puppy commercial on, okay. And you get me started on my brand new German Shepherd puppy, I won't stop. But it almost brought a tear to my eye to watch him chasing through Dr. Machado's office after his one-year-old son, trying to catch him. Because we knew, literally, he had trouble getting out of the wheelchair and getting into the bed when we did his procedure. So this is one of the biggest things that is just absolutely awesome for us. Not only is it awesome for our patients, but from the impact it's had on the medical community. And that's why there's been such a fight. Everyone's like, I don't want to put the $65,000 device in the patient. But the flip side of it is, over the next 10 years, you're going to save millions of dollars on that patient having to go into the hospital. He's still going to die in 7 to 10 years. Not this viral guy, he only had the one issue, but all these people that have all these really bad EFs, they have so many comorbid problems, they're just, they're toast.
Kidney failure.
Kidney failure, high lipids, diabetes, some of them won't quit smoking, all kinds of crazy things. But this alone reduces the burden on our community, our medical community, on price, and actually makes our patients feel better while they still have some time left. Sorry. I always have to do that with that one because that was like that was like a really cool time when we're seeing all of this happen, and you know, it's like you get to be in the joy of discovery, and it's like, wow, we really truly are on the cutting edge. All right, so there's still cutting edge stuff happening in EP. You gotta get in on it because it just makes your life like awesome. All right, so a basic EP study is designed basically to test for both brady and tachyarrhythmias. If they have a bradyarrhythmia, then we're probably going to put a device in. Because there's nothing I can do in the EP lab to fix your bradyarrhythmia. Now, just as an FYI, this is why, you know, checking with, you know, doing a good H&P and knowing about your patient before you bring them to the lab is a good thing. I got a question. On all of our consults for bradycardia that we received in the cath lab, and the EP lab, excuse me, what was the number one order we had when we got that consult? Because they're like, oh, they have a patient that's got bradycardia, you need to put a pacemaker in. What was our number one order that we would have on that patient before we would bring them into the lab? Tox screens. DIG specifically. Also, we review their chart to see how much beta blockers there are. I would say a good 40% of our patients were poisoned by their own physicians and didn't require our intervention for bradycardia.
Seen it a lot.
Mm-hmm. So keep that in mind. All right? If it's a tachyarrhythmia, we may fix it, we may not. It depends upon what kind it is and what type it needs to be fixed. All right? When we're talking about tachyarrhythmias that we wouldn't have fixed, we're talking like our VTs and VFs that are usually somehow structural heart relation. When I say that, that means we're talking about ischemic cardiomyopathy, or even now with SCUT-HF, just regular cardiomyopathy. Just the fact that you're stretching out the cells and the walls of the heart. Hypertrophic cardiomyopathy would do the same thing because now they're all tight and bunched together and irritating each other. So we don't normally fix that type of stuff in an EP lab. We may do some work, but that's usually after they've gotten the device and they're just getting shocked every day. So we may go in and try and find the substrate that's causing that shock every day. But like in an ischemic cardiomyopathy, if we tried to fix something like that, we'd fix one substrate, and then we'd have to go to another one, and then we'd have to go to another one, and it'd be a 7-day case. And by the time we're done, we probably burn so much heart that now now it won't beat. So, so what do we have in an EP lab? The very basic things we have is we have an EP recording system, we have a stimulator, we have EP diagnostic catheters, we have an X-ray system. You guys have been in the EP lab, you see all this stuff. But this is the very bare minimum. Not to pick fun, I won't say who did it, but I actually heard about a company that sold a hospital an EP recording system but forgot to sell them a stimulator, so they couldn't do any pacing. So the doctor walked in, took one look at it, canceled the case, walked out, and never went back to that hospital again. Because they wanted to start a brand new program and figured they can't give me the basic equipment and don't even know what it is and can't bother to ask. There's no reason I want to practice here. So,
Tell me.
You want to know who?
Yeah.
It's more a company thing than it was anything else.
Okay.
It had no less. The hospital was asking the company, and the company should have been smarter than that. Anyway, they have a really crappy EP system. The EP recording system must be able to do 12 leads, and I cannot stress this enough. And I stink at 12 leads. With all my experience, I stink at them. Because one of the things we do with 12 leads is not necessarily look at it and say, oh, look, you're having a heart attack. But during the arrhythmia, a 12 lead will tell us what chamber it's coming from and can actually shorten your EP procedure significantly because you know where to look. And I stink at vectors. I can do ventricular vectors, but I have to sit there and go like this, and squint and think, and you can smell stuff burning. And then I'll be drawing Eindhoven's triangle in the air, and then eventually I'll be like, it's on the left lateral wall. And usually the cardiologists are looking at me like this the whole time. Really? And God help me if I have to deal with it with an atrial, with a P wave, trying to figure out a vector on a P wave. I'm useless at that one. All right?
But like the P wave vectors either. I don't teach those here.
But the other flip side of it is I also didn't spend 2.5, 3 years as a cardiology fellow looking at 10,000 EKGs, 12 leads. I don't have a problem with that. I drank a lot of those years away. Had a really good time. So most of the cardiologists I know are just learning how to drink. All right? You have to have multiple input channels for these intracardiac signals. We're sticking a whole bunch of electrodes inside of the heart. And when I'm talking to like the regular people, it's like, what do? Well, you know how you get a 12 lead? Well, we do that from inside the heart. We stick a whole bunch of electrodes inside the heart and basically do a 12 lead from inside the heart. Try and get more detailed with that, and their eyes are going to roll into the back of their head, and they're going to like glaze over and fall asleep. But you have to have inputs for that. Most systems have somewhere between 64 to 96. All right, different channels. 126 or higher is not uncommon, but that's literally a doctor who literally wants to be able to go, my AP amplifier is bigger than your AP amplifier.
Who does 126? I mean,
Ever
really?
since basket catheters went away, it's pretty much useless, and it costs the facility about anywhere from $90,000 to $200,000 more to get an amplifier with that kind of capability.
Wow.
So.
It's like a waste of money.
Yep. But some doctors gotta have that big amplifier. If I don't have a big amplifier, I'm not a real man. All right? So, do not ever tell anybody that the guy from GE said that I was challenging the physician's manhood. I'll hunt you down and find you, okay?
We won't say a word.
All right. You have to be able to record these signals simultaneously, and you have to do it at a very, very fast sampling rate. The minimum sampling rate by at least my company's standards is 1,000 times per second. You've seen how we stress the signals out. At 1,000 times per second, you have to have a sweep speed of 150 millimeters per second in order to see all of the information that we're gathering. All right? I do have some research labs that I work with that they're sampling at 2,000 and 4,000 times per second. All right? But that's only research. And you must be capable of reviewing these recordings, and this is where all the computer stuff came in. It wasn't until we were able to restore this information. I mean, think about it. Every single one of these channels, we've got 12 surface leads, 4, so that's 16, so I'm looking at 28, and then we do another 5 on top of that, so we're 35, 40 channels easily on just a basic EP study, and we're sampling at 1,000 times per second. It's a lot of data moving very, very fast. We have to be able to record it and review it back instantaneously. And that's why it took so long for EP to really get going. Because not to pick on our cath brethren, but basically, you know, they're just looking at an image, and when they inject something, if it doesn't go anywhere, and the hemodynamics is another big portion of it, especially now that it's coming back, but even so, they're only doing a 12 lead and a pressure channel. And their sampling rate is, I think, about 50 times a second instead of 1,000. So that's always been the biggest problem. When we're looking at data storage for EP versus cath, we're looking at one EP case was the equivalent of over 20 cath cases.
Mile deep. Inch wide, mile deep. That's EP.
And be careful, you'll drown. So I like this picture because this was my lab when I ran it. And it brings back lots of warm memories. Up to and including our little Beanie Babies right here. So the Beanie Babies were very important. Mostly we had one that was a little parrot. And one of my staff, she would walk around the last patient of the day like it was a dead chicken, shaking the dead chicken of the patient, going AVNRT, AVNRT. Something simple so we could go home soon. Then we had our little octopus and our little bear. And when the doctor lost his temper, the octopus would attack and kill the bear. Needless to say, I ran a very strange group of people. We also have our amplifier, and this is just our basic amplifier. It doesn't matter what company it is, and just so you know, a lot of the signal stuff I'm talking about, it doesn't matter what company you're doing it with. All right? There are various ways that you will have to set it up differently on each machine, and I'm only showing my companies because I actually like my company, and that's why I went to work for them, not the other way around. All right? I've worked on the other systems. I think they all suck. So, but that's my disclaimer, and I do work for the company, and they pay me, so you don't have to listen to me. All right? But as far as like manipulating the signals and dealing with different things in the various pieces, it really doesn't matter. An EP recording system is an EP recording system is an EP recording system. All right? You got to have your monitor so you can see, keyboard, and some sort of controlling mouse device thingy. And we used to use trackballs. Now we use mice because apparently we finally stepped into the 21st century. We have our amplifier, which is the thing that processes all the signals and turns them into a format digitally that the computer can use. We have what we call catheter input modules, or SIMs. Everybody just refers to them when they're talking about our product as the blue box. Have you plugged everything into the blue box?
Everybody calls them pin boxes anymore.
Or pin boxes, that's what
Okay.
they
Do
say.
they?
Yeah.
Okay.
Pin boxes, I just call them the blue box.
All right.
So.
Okay.
And this is where you plug in the cables that come off the catheters. We also have to have a stimulator. It has to be able to pace at various speeds extraordinarily accurately. It'll have several pacing channels, and you usually can mess with the pacing trains and change the timing in between different beats and how you deliver it. All right? This is our stimulator. No.
Oh, sorry.
It's
What's old?
It,
It's antique.
it's hold on.
It's a collection. It's not old, it's
It feels so
ancient.
much better being able to touch that. We don't sell these anymore, unfortunately. I grew up on this particular stimulator. I was the person that was referred to in the lab as the one that was not scared to push the big red button. Second week I was in the EP lab, I flicked one of the switches right there in the wrong direction and paced the atrium at 50 milliseconds and found out that if you do that, you can cause fibrillation. Luckily, it was in the atrium. My good friend, mentor, and awesome electrophysiologist who was counseling me at that particular time refused to speak to me for over 24 hours. Didn't yell at me, wouldn't speak to me. Next morning when I came in, he looked at me and says, it's a brand new day, brand new opportunity. Everybody gets a chance to start fresh. That was the only thing he ever said to me about it.
And he didn't say, don't touch that button? Don't touch
He
that
didn't say don't touch that button. In fact, he put me right in front of that thing again. Tell you what, I never made that mistake again.
No.
In fact, I almost haven't made any mistakes on a stimulator since then. I've been very, very careful.
What's the big red button?
The big red button, that's a high output pacing for one of the channels. That's all. So, in this particular case, so long as the settings on here isn't bad, you can push the big red button. It doesn't cause any problem. They said that about me because I had no fear of doing anything when it came to technology. I'm not sure that was a good thing. I learned very fast. When I teach classes, I try and teach them in such a way that you can benefit from the knowledge of my mistakes so that you don't have to make them, because I made a lot of mistakes. All right? But I learned very quickly because I made a lot of mistakes very quickly and moved on very fast. All right? But I love that. There's two other main stimulators on the market. One's called MicroPace and one's called the EP-Med stimulator. It's sold by St. Jude. MicroPace is actually an Australian company, and it's sold by Bard, GE, and they sell it themselves. They have an office based out of California. They're digital stimulators. What's really nice about them is that those digital stimulators will never let you accidentally pace in a chamber at 50 milliseconds. What I don't like about them is that you pretty much you don't have to know what you're doing, and you can probably survive doing pacing in the EP lab. The issue is, this is, in my opinion, the most dangerous device in an EP lab, other than the physician. Because this device is designed to induce arrhythmias. Some of them are lethal. And if you don't treat it with the right respect, you are going to be in a problem. And even if you are doing everything right, if you don't have enough knowledge to correct what you just induced, you shouldn't be sitting there either. So I have a big issue with this. And don't get me wrong, if they let you play with it, you need the experience. But understand what this is. This is designed to kill the patient on the table, and it's very effective at it. With this device, I don't care who you are and what your health condition is, you could be a marathon runner. I can guarantee you I can put you into VF. All right? Because that's what it's designed to do, and I can do it. So I kind of like to warn people a little bit about this one. All right? So obviously we need a doctor. And in this particular case, we have a doctor and a fellow. All right? And then, of course, we have our various catheters. You know, the names of the catheters are not as important as you just need to know there's a name for everything, and they change from company to company, and they usually designate how many electrodes, what kind of curve it has on it, and a whole bunch of other stuff. And depending upon the name and how many letters and how many electrodes, the price of the catheter goes up. All right? The biggest thing you need to know is that each of them has electrodes on them. They can have various different spacings, but the most common is somewhere between 4 to 10. All right? And they all have a separate cable. And this is the fun part. Every catheter has its own specialized cable so that you can plug it into that pin box. And you've got to have the right cable. And if you really want to see an EP doc lose his cool, have the wrong cable. All right?
Or tell them you don't have the cable, we're out of the cable.
You know what's really fun?
We have a cable today.
What's really, really fun is when they get, like, do a transeptal case and they finally get their ablation cable across, or their ablation catheter across, and you've got it hooked up to their cable, and it gets in the right spot, and they go to burn, and they realize because they've re-sterilized that cable like 15 times, there's a problem with that cable, and all of a sudden they go, bam, and you can't do anything. You really want to see a doctor get really happy. Tell him he can't, when he's finally found the right spot that he's just worked 2 hours to get to, that he needs to wait until we get him a new cable, and please try not to move. All right, so your basic EP study combines a 12-lead, your intracardiac signals, SA nodal testing, if they still do it. Still on, I think it's still on the CMS complete EP study. AV nodal testing, and then you work at atrial arrhythmia induction and ventricular arrhythmia induction. Catheter placement is rather straightforward. I like this, though it gets a little confusing. But you can see we have a catheter that goes into the coronary sinus. We've got one here that's at the bundle of His. We've got one that goes down here. Yeah, that's right. I'm sorry. I'm getting a little confused here. And then we have one that's up here at the top of the atrium. And these are the different signals that are, this is your bundle of His. Most people call it His, but HPV, His bundle. You know, CS catheters and RV. I know when she talks about arrhythmia interpretation, she's going to go over this, but just to kind of help you out a little bit, when you're looking at your signals, ignore the CS. Because there's way too much stuff going on in that screen. And until you get good, it's going to be a while until you can do that. Because what we need to know is how the arrhythmia progresses from the top to the bottom and back to the top again. So it's high right atrium, His, and RV. Those are the only signals you really need to concentrate on. And then once you figure out what's going on and what kind of arrhythmia is, then you start looking at your CS arrhythmia to see whether it's on the right or left side. So top to bottom, bottom to top first, then right to left. Because it doesn't, I had a guy in my EP lab, I won't mention, he left. He had ADD really, really bad. I mean, I think I'm bad, but he really did. And we would just fire up our system, and he'd see all those tracings of the pretty colors, not even have anything on it yet. And he would stop and freeze and just stare at the screen for like 30, 40, 50 seconds at a time. And then when we actually started having stuff, and it's like, I'm just like, dude, just look at this, and this. You only have to worry about 3 signals right now. Just trying to teach him. So, but it can get overwhelming very, very fast. So take it, you know, it's like, I don't know why, but my favorite phrase for the last 3 months is, how do you eat an elephant? One bite at a time.
How do you what?
How do you eat an elephant? One bite at a time. Take things, little bits, and as you keep going, you'll get there. You might take a while to eat your elephant. All right? So we end up with all these cute little intracardiac signals. All right? When we're doing them, she's talked about doing all this. We do atrial to baseline, atrial to atrial, ventricular to ventricular. This is a PR, QRS, QT, AH, and HP. And she's been talking to you about these, so all these numbers should make sense. Just so you know, use her numbers, not mine. They change from physician to physician anyway. So start with her stuff, and then when you get in the labs, the doctors may have their own. I've seen doctors that don't care about QTs until they're past 700, and I see some of them get a little freaky when they're at like 325s. Okay? This just kind of helps. Remember, there's one that's wrong here.
Oh, yeah.
So there's a bonus point here with my measurements. You can figure out which one of these slides is wrong.
I always forget.
All right?
So this one's easy. This is 8 to 8.
Yep, this is an A to A measurement. As you can see, we just measure from our A to our A. All right? And not a big deal. It's just sinus cycle length. Okay? All right. So this is our V to V. So we measure our V signal to our V signal, and this is maybe slightly different than your A to A based on incremental, decremental properties and a few other things and rate changes. Then we have our PR interval, and you can see we're measuring from here to here, beginning of the P wave to the beginning of the QRS. Same thing that we always do, right? Then we have our QRS, right? Beginning of the QRS to the end of the QRS. No big deal. All this is pretty straightforward. This is stuff you've gone over with. That's why I'm going fast. So we have our QT.
Yep. That's not the error one, but.
Yeah, but it is. It should be there.
Oh, this is the one?
I think so.
You can tell the red line.
Yeah.
Yeah.
Yeah. That's it.
Oh,
right
yeah,
there.
yeah.
Yep.
Right.
That's the error.
Right, the two
By the way, this is a common mistake for new people. Doctors usually won't correct you, but they'll but then they'll just realize you don't know what you're doing and not respect you for another 3 to 5 years. These doctors are very forgiving people.
What?
Yeah. So, oh, this one was also an error. Boy, I did a lot of mistakes. I must have not had any coffee when I did this one. It's the A to H, and it's measuring from AA1 to H1. It's not actually measuring from H1. So it's not measuring.
Oh, gotcha.
You see what I mean? You guys understand what I'm
I don't
saying?
even see the 8, but I don't have my glasses.
The H's are, as Christian and I would call it, it's our imaginary H. All right. Hey, technically speaking, unless we do something like burn it, your HV will never change. It's a static signal. So a lot of times when we couldn't get our hiss continuously, we'd measure it once, and then that would be sort of our imaginary jokey hiss. We just were looking at the V signal and say, well, the hiss must be right about here. So when we were trying to figure things out. Not optimal, not good, but it was one of our tongue-in-cheek things. It's like, they're like, well, I think it's doing this, and I'm like, yeah, because the imaginary hiss says that it's got to be going, and Christian would look at me and be like, so, all right. HV is correct. And Fulgarose actually changed their little bit. I don't know if I mentioned that last time, but originally Fulgarose said it's supposed to go from the H to the first V signal. Now it's actually saying from the H to the surface beginning of the QRS.
That's how we're teaching.
Right. Pacing trains, they establish a constant rate for testing. She's gone over the idea between incremental, decremental properties and all that, right?
No, we're starting on basic EP study next week. But
Okay.
they know what S1, S2, S3, S4 is.
Okay.
Yeah.
So one of the things we try and do, because despite what everybody thinks, EP is not witchcraft, it's not voodoo. It's science, all right? And we try and minimize all the variables that we can. One of the ways we do that is when we're doing an S1, when we're doing a pacing train, we will pace consistently at the same rate and then do whatever our test is. And the reason we do that is because a lot of tissue properties in the heart change by rate. So that's what that S1 train is when they're talking about pacing. It's literally, we do an S1 and then the S2 is the PAC or the PVC. That S1 is specifically to make one of our variables not change. because this is actually science. It's not witchcraft or voodoo, no matter how many times we wave the dead chicken at the patient before we start the case. All right? SNRTs could be defined two ways. The easiest way, this is sinus node recovery. We don't see this a lot anymore because it really doesn't do anything for us. It was really cool when the paper came out in the late 80s, early 90s. It was like awesome because it would tell us that our patient had sinus node disease, but we wouldn't know what kind of disease. We just knew their sinus node was sick. It could be tachybrady, it could be bradycardia, sinus arrhythmia, anything. Now we have Holter monitors, digital loop recorders, stress tests. They have access to a lot more information. We already know that their sinus node is messed up before they get into the EP lab. It's pretty much a useless test for us. But Medicare, in their infinite wisdom, still requires it for you to bill for a complete EP study.
Oh my goodness, really?
Yeah, because our insurance companies are that much in tune with practice today. All right? So when we're defining it, this is the standard way that you see most of the time. You get your corrected SNRT, you just take your cycle length, and you take your SNRT and subtract your cycle length, and then you get what we call a C-SNRT or corrected SNRT, and so long as it's less than 550, everybody's happy. All right? The other way is you can do this ratio where you do the SNRT divided by the basic cycle
That's
length
in
times
the
100, and then
did
you,
that.
yeah.
But I told him not to worry about that one
Yeah.
because it's not on the RCES.
Really?
It's not. The corrected SNRT with the CSM, 550 is a number used on the RCES
Okay.
exam.
I
Not the
remember.
ratio.
Yeah, I remember having to deal with that.
Yeah.
But-
Oh, I can remember doing it.
So, oh, wrong direction. Here we go. So this here's just a SNRT study, real quick. They did it, and then they stopped pacing, and then we would measure it. There we go. This is actually measuring it. You can see that this is our final beat, and then we measure to when we actually get our sinus node back, and it does something. And the idea behind a SNRT is really simple. You know, we all know that whoever's pacing in the heart fastest wins, right? I think I stole that phrase from you. All right? So if we're pacing in the heart rate, the SNRT's just like, the sinus node is literally just like, good night, and you go to sleep, you guys take care of it for a while. And he goes to sleep. And all of a sudden we stop, and it's like, oh, shoot, I got to do something. It's that length of time it takes for going from being asleep to doing something is what we're testing. Okay? ERP of the AV node. This goes back to that whole action potential curve. I've got a 4.5, 5-hour lecture on it. I'm sure she's even got more. But it's all based on the idea that we want to know when a stimulus will occur again. And if it happens too fast, it won't do anything. And that's what we call ERP. The rest of the world calls it absolute refractory. But we call it effective refractory because we're EP and we have our own language and we're elitist and they don't know what we're talking about. All right? So we have something called functionally refractory, which means it's still in its refractory period, but we can still deliver a stimulus and it will pace. And that's what we call it. It's called FRP because we're elitist snobs. And the rest of the world calls it relatively refractory. But if you don't use the right language in the EP lab, they won't talk to you. All right? You can see it here. We delivered that extra space, and then we just followed this to see if it paced. And did it capture? Did we get it? Oh, so that would be the ERP. This is a ventricular extra stimulus. So we paced to see if we could do something really, really nasty. And we did. All right. Now you want to know the fun part? This is the important part. Bonus question. It doesn't get you anything other than I'll smile at you, and I know how much you adore me already, okay? What will we do to treat this? I know, in this particular case, their electrolytes should have been okay at this point. But that's an interesting point.
Did we do this?
I mean, we would treat this by obviously fixing the arrhythmia, but what would we do? I mean, we saw this, we induced this arrhythmia in our procedure, so now what would we do for the patient so that going forward they would be happy and healthy and okay?
Premature.
Defibrillator. Anybody else? ICD. Thinking.
Overdrive. Pacing.
Yeah, it could be done with a defibrillator. Send them home on antiarrhythmics. Those are what you would think. Do you want to know what the answer to this is?
PVC.
Not a thing.
Oh.
It's not clinical by the standards of the time. You see how everything sort of changes and moves around? This is a monomorphic VT. Monomorphic VT induced in an EP lab is a non-clinical.
That you call that monomorphic?
I'm sorry. Polymorphic VT.
Okay.
Thank you for the catch. I apologize. This starts scratching. I apologize.
Yeah.
Polymorphic VT
Right.
induced in an EP lab does not require treatment. That means we were too aggressive.
And we caused it, and it
We
doesn't
caused
mean
it.
that
It's
they're going
not
to die.
clinical. VF caused in an EP lab is non-clinical. We were too aggressive. We shouldn't have been that aggressive. The only VT that's treatable from something that we've caused in the EP lab is monomorphic VT, as defined by MATIC 2 as being 15 beats or more of sustained monomorphic VT.
Is that what you use, 15 beats, not 30 seconds, not 7? Do you see different numbers?
MATIC 2 specifically said 15 beats,
Okay.
or it might have
Because
been,
it's ischemic.
or we always counted 15, I think it was 14, whatever, but it has to be
All right,
15 beats,
All right.
greater than 14. So we would count. If we got to 15, we'd call the device down. But it has to be monomorphic, not polymorphic. Just so you know, we didn't send the patient home in that rhythm, okay? We did do something. All right, before we get to this, I'm a little disjointed because I haven't had time to work on this, so I apologize. But we're going to talk a little bit about signal manipulation because when we really take a look at, and I actually, this is new because I actually had to write this, and I've been doing this as a lecture for my customers. All right, this is all about how signals happen. Because what we're really doing is we're looking at electrical signals here, and the truth of the matter is it's almost equivalent as to tuning your car radio into the right radio station. Okay? So we have to remember that each one of these signals that we're looking at is a representation of an antenna. And we have two types of antennas in EP. But no matter what they call them, they have to have a positive and negative in order for the antenna to work. All right? And one of the signals which we are not going to cover today, the unipolar ones, people forget about that negative signal. You don't know how many times I get calls going, I can't get my unipolar tracings to work. I'm like, so what is your negative ground reference? What are you talking about? All they need is the positive. All right, let's go back to EP. It's a 200 EP. Let's go back to 200 EP and talk about how signals work again. So, the leads that we're talking about, the type of it, basically have two types. We have endocardiacs, we have surface leads. All right, very straightforward. But no matter how you look at it, even your surface leads are antennas. Okay? And because of that, we have to be able to set up the antenna correctly so that our DJ, when he's playing the music to us, can actually give us the information that we want. All right? So when we're talking about antennas, everyone usually thinks that this is an antenna. And specifically in EP, we're talking about our different catheters as being an antenna. But another important thing when we're talking about signals is people are antennas. All right?
Who are those people?
Well, the first two are my parents.
Well, that's your mom and dad?
Uh-huh. This last one is my niece and her little dog, Coffee. All right? Very precocious child. I pretty much am figuring by the time she's 18, she will be ruling the world, and we will have to bow to her and give her donuts. All right? And she's already got me doing that right now. Anyway, so there are two aspects of a signal when we're talking about it. We're talking about frequency, which is how fast it goes up and down, and amplitude, which is how strong the signal is. So we have speed and strength. Both of these are very important when we're trying to get these signals to be able to do something, okay? When we're talking about it, the speed and strength, the frequency and amplitude reflected in the tissue shows us many different things. speed is based off of connectivity, and that's our frequency. All right? Healthy tissue has strong signals. You see what I mean? So how fast is it going? Within the heart, we have regular tissue, we have avinodal tissue, and we have pathway tissue. Interatrial conduction pathways, the His-Purkinje network, our bundle branches, all of this stuff. Those are our pathways. Each one has its own speed, and depending upon their strength for that type of tissue, will either be really, really tall, or if it's sick, if you've got somebody that's really, really strong and healthy, they're like, hey, how you doing? What's going on? What's right? And then, of course, you have your poor little grandma who's like, just don't feel very well. Get there in a moment. Don't wait for me something. Okay, I'll be there. All right? So signals within the heart represent the same type of thing. Okay? Unhealthy tissue will conduct slowly with a low amplitude. And anyone know what the one exception is?
Heavy note.
Yep, AV node, because it does some weird things. All right? So, because the AV node has weird decremental properties, she's going to get into that, but it's the only tissue in the heart that does that. Okay? All right, so we have two types of signals. We have something called a bipole, which you guys have all seen. Those are those sharp little spikes on our inner cardiacs. All right? Bipoles, they have short antennas. Because they're little tiny antennas, they're naturally filtered. They pick up less information. All right? Requires two electrodes relatively close to each other. This is one of the most important things when we're dealing with EP, and this is what screws people up a lot, is it only displays local activation.
I've already said that like 5 times.
This is a big deal. When you see a signal in your high right atrium, it's not showing you that the atrium is depolarizing. It's showing you that the 3 or 4 millimeters of tissue that that electrode is touching is depolarizing. There have been many times in an EP lab when we're looking at an arrhythmia and we're like, what the heck is going on? And then finally someone clues in and they say, can someone step on fluoro? And we realize that our high right atrium has fallen in his ventricle, and that's why nothing's making sense. So you have to know where your catheters are, because that's only going to show you what the tissue that's it's touching is doing. It doesn't show you the rest of the chamber. I don't care what the label says. All right? And then what we do is we compare the timing of the signals to other electrodes. So we can literally say, so this is up in the top of the heart, and it went first, and this is in the middle of the heart, and it went next, and this is in the bottom of the heart, and it went here. So basically my signal, my electrical signal must have started here and gone all the way down here. Because it's all about timing. Specifically with bipole electrograms, we don't care about morphology until we really start getting to the advanced stuff. It's not like we're looking at a QRS and going, oh, that's a PDC, or that's normal conduction. All we care is when that signal starts, so we can say that tissue depolarized, what's next? Okay? So local activation is very important. And it's the most common. Just so you know, it wasn't the first. We started using unipolar signals first. The problem with unipolars is they have no natural filter. They're big antennas. They pick up all kinds of information. We switched to this short, naturally filtered system so that we could see our signals better. Now, however, we're coming back. We're going the other direction. It's always fun to see when a doctor says, I'm going to try this new unipolar thing. New. Oh, okay, whatever. Because it's not new. It's old school. But we're bringing it back because it does give us a lot more information. But it is a big antenna. It picks up lots and lots and lots of information, including your really, really noisy hairdryer that the girl's using in the locker room right next to the lab. It can pick up electrical interference like that. So we have a lot more issues with noise coming across those because of that. It will pick up more. It doesn't even matter what my filter settings are set to on my computer. Okay? It still requires 2 electrodes, but you've got one in the heart and one somewhere else, instead of having 2 in the heart right next to each other. Okay? Both of which have to be connected to the patient, because if one isn't connected to the patient, it can't pick up anything. The difference here is it doesn't just display the local activation the way this one does, it also will display distant activation. And I'm not going to go into that, but I'll kind of show you a little bit. but you get a lot more information. You can actually find the signal as it comes closer to the electrode, and then you can know as it goes away from the electrode. All right? So it doesn't just tell us when it depolarizes, it tells us as the wavefront comes towards and away from that particular point.
That's that Goldberger's thing. If it's coming towards you,
You know, the train.
that positive thing.
Meow.
It's positive, it's coming towards you. If it goes away from you, it gets negative.
I like mine. Meow.
Okay, that's good.
Come on, I'm a guy. I have a little remote control car I play with the doggy. Anyway. Instead of using it all the time, like when we first started doing EP, now we use it specifically like for our mapping category to figure things out. Okay? So when we're doing bipole pairing, we're like literally taking one electrode and connecting it to another. All right? Depending upon the size of the distance between the two, because literally the antenna starts here and goes all the way to the end of this point. So the bigger the spacing, the larger the electrode, the bigger the antenna, the more likely you are to get noise and problems. It's why our diagnostic catheters that have a 2 millimeter electrode, a 2 millimeter space, and a 2 millimeter electrode are some of our clearest signals. And then you stick an ablation catheter up there with an 8 millimeter tip. So I went from 6 to 8 plus 2 is 10 plus another 2 is 12. I've doubled the size of my antenna. All right? So I'm going to get a lot more information, and some of that may be information that I don't care about. I really don't care about the fact that the IV pump is working next to the patient. Okay? Remember, it displays local activation. You get this cute, nice, little, pretty triphasic waveform. It goes down, it goes up, it goes down again. All right? Or maybe it goes up, it goes down, it goes up again. Whatever. It's what we call a triphasic waveform. When we're looking at it, we're not caring about the morphology for the most part. There's a point where you will, but not now. Okay? We're caring about that little spot where all of a sudden we see it start. Because when I see it start, I know that the tissue that it's touching is now depolarizing. Make sense? So this is a bipole configuration. The distal electrode is always negative and the proximal electrode is always positive. Why? Makes no difference for a display. Remember how I said morphology doesn't make a difference? Because it's all about pacing and making sure that the computer knows how to pace correctly if you select this electrode pair. Because when you're pacing, the thing that's touching the tissue has to be the negative electrode. Because the negative electrode is the one that's losing electrodes. And I like to think about it, it's my super soaker electrode pacing gun. All right? It's spewing out electrons into the tissue. So if this isn't negative, it's not going to capture. All right? It has to shoot this out so you can get captured. So our distal is always negative when we're building study configurations specifically for pacing reasons. Okay? Does that make sense? You were squinting your eyes at me. Okay. All right. All right. So when we have our electrode in our atrium, as you can see, if I put it right here, all it's going to do is show me that this is what's currently depolarizing as that happens. And that's when I'm going to see my cute little spike. All right? All together now. Never mind. Anyway. She warned you I was insane, right?
No, I did not.
Okay. Bad, Lori. Bad. All right. And then, of course, this is what we see. So that little bit of atrial tissue depolarized, this little bit of atrial tissue depolarized. Because this is at the top of the atrium, this is at the bottom of the atrium. All right? And I get my hiss, just so you know, this is typical of what you'll see for hiss. It's that little notch right there.
Oh, we saw that.
Of course I saw that. And then we have our V signal. Now this is a fun one. Okay? Because remember, we're showing the local tissue depolarizing, right? So this is a V signal and this is a V signal. Why do you think this one's earlier?
It's moving its way back up.
It's moving its way back up. Remember our depolarization on a normal sinus functioning heart beat the way it's supposed to. Atrium, AV node, down the septal wall in the ventricle, up through the lateral walls, and across the base, which is the top. Depending upon how that catheter is sitting, it's either on the septum, and this is going to be first, or it's rotated a little back, and it's actually kind of resting on the roof of the ventricle, right underneath the annulus, which is the last thing to be depolarized. And that's why this is in our apex, and that's later. Does that make sense? This is one of the classic showings and discussions that proves my whole concept about local activation. Because you would think that this would probably be behind this one. But it will change based on catheter position within the patient. Not on the patient, but on catheter position within the patient. Okay? Unipolar. Well, instead of using all these wonderful electrodes we have on this, we usually just use the tip, which is our mapping catheter. And we normally only use unipolar except for a couple, I'm up to 3 now, crazy, insane physicians that like to do some weird stuff. And it really annoys me because they can't figure out how to set it up. So unipolar, we're usually only using our mapping catheter because remember how I said it shows as the wavefront comes closer to you and then it goes away from you. So it gives us an opportunity to play Marco Polo with a lot more information when we're looking for arrhythmias. Okay? Because if I have a catheter here and I know that I have one signal and I move it here and it means that it's moving farther, I'm getting farther away because they get a different waveform pattern, then I can actually move it around in a 3-dimensional space and get there a little faster.
Do you guys know what Marco Polo is?
Oh, I'm sorry. It's a game you play in the water.
Swimming pool? Yeah. It's like a hide and seek game called Marco Polo.
So the person that's it has to keep their eyes closed, and everyone yells Marco, and then they yell Polo, and the person with their eyes closed has to find the person.
That's where you yell Marco.
So you're hide and seek in the swimming pool. And if you are out of the water and the person who's it says Marco, you have to say Polo, or you have to go underwater so they can't find you.
Sorry,
I've played this game my whole life.
I apologize, my silly, stupid United States American idioms. But it also kind of describes my whole bad cultural, I actually spend a lot of time watching what Brittany's going to do next because it's just humorous. So this is what we're talking about here. Unlike when we talked about with the bipole, we always wanted the distal electrode to be negative. At this particular time, the electrode that's on our mapping catheter is positive. And then our negative is somewhere else. So this would be our mapping catheter that's positive up in the heart. And the 2 places that we see this, the best one according to the literature is supposed to be in the IVC underneath the diaphragm. And that becomes our negative electrode grounding reference. Another thing we can do is it's called a Wilson common terminal or a Wilson central terminal or whatever. And it actually uses the ECGs on the outside of the body, the patches, as its negative grounding reference. The problem with that is that it's on the outside of the body, and the skin sort of acts as a natural filter from all the crud that's going on in the room. So now you've got signals that are out from the inside of the body that are amplified extraordinarily so you can see what's going on, that are all screaming with noise that's coming from your IV pump, your mapping systems, fan that's keeping your computer cool.
Do a lot of places use the catheters, the mapping catheters, and that have a negative electrode incorporated on it that, like you said,
Not the mapping. There's not one with the mapping catheters because I don't think they have enough room without making them too big.
Okay.
But they do make a Josephson and a CRD2 that's a hexapolar. So it has 4 poles at the tip and then 2 poles halfway down its body. And then you can plug one of those 2 poles in to use as your negative reference because it would sit in the IVC. And theoretically, the reason it's a hex and you have 2 is that you can use one for getting your signals, and then if you really are crazy and doing some bizarre stuff, and just so you know, 15 years, I only did this once, but start pacing unipolar and using that as your...
Is your neck?
Yes. 15, 16 years, I've done it once. And I did it in the third week I was in the AP lab.
So the mapping has a positive distal electrode versus negative.
Correct.
Unipolar.
Only for unipolar.
Right.
Only for unipolar. If you're mapping and you're just using bipolars, the distal will always be negative. Okay? EP's like the English language. We have a rule for everything, and then we'll break the rule like 10 minutes later. All right? You guys are probably dealing with that a lot too. The English language doesn't